Good morning, good afternoon, or even good evening, depending on where you're coming from. Welcome. My name is Dr. Christopher Tarnay, and I am the Chief of Urogynecology here at UCLA in the Department of Obstetrics and Gynecology. And today we're going to talk about female bladder leakage, and we're going to focus in on solutions. Solutions how to get control of this very challenging problem for women. So, during the webinar, feel free to ask questions. We've got Cleve over here. He's monitoring our Twitter account. You can use the hashtag UCLAMDChat, UCLAMDChat, or you can just put comments on Facebook. And during the webinar, we'll be tracking them, and at the end, I'll address some questions. All right, I'm going to start off with some geography. Does anyone know where this might be? This is the Blue Ridge Mountains, and it's in northern part of Virginia. I had the opportunity as a medical student in Georgetown when I was in DC to go and visit them. And one thing I didn't know at the time was that the Blue Ridge Mountains and the vagina share something in common. I hope I have your attention now. And what they have in common is similar topography. Women have estrogen, and estrogen in the vaginal area creates a thickening, and that thickening creates small little buckling of the tissue, creating tiny folds called rugae. And these rugae are very important. They create a functional impact on the vagina. It has rugae to allow lubricants and secretions. It also, those rugae allow stretch, and the rugae are like this peaks and valleys. And that stretch allows function during childbirth, during intercourse. And the problem later on, as estrogen decreases, either during menopause or estrogen decreases during breastfeeding or after childbirth, is that that elasticity goes away. The vagina tissues can flatten, and those rugae flatten. It becomes thinner and drier. And that can lead to challenges during these transition times with intercourse. Also, bladder control. And that's what I want to talk with you about today. Female bladder leakage is urinary incontinence. What is urinary incontinence? The involuntary leakage of urine, or simply put, urinating or leaking urine when you don't want to. One of the biggest questions patients have for me when they come into the office is they feel kind of isolated. And I go, is this the only thing happening to me? Is this urinary incontinence? Am I the only one who has it? And it's important that you know that it's extremely common. 2 out of 3 women have a lifetime risk of suffering from urinary incontinence. Now, although incontinence increases as one gets older, it actually can happen any time during the lifespan, and women can experience symptoms at any time. It affects over 200 million people worldwide, and in the United States alone, at least 25 million. And of those 25 million, 9 to 13 million women have either bothersome or severe symptoms. How about a few more facts? Urinary incontinence is underdiagnosed. It's underreported, and as I mentioned, it increases as we get older. It's primarily a female problem, as over 2/3 of people who have urinary incontinence are women. There was a study looking at random sample of 45,000 different households. And during that survey, 37% of the women reported incontinence just within the last 2 months. In the elderly, over 70% have complaints of urinary incontinence. And this alone can be the reason for elderly individuals to be transitioned to a different living situation, to a skilled nursing facility, to assisted living, just to manage the incontinence. This graph shows that as we get older, urinary incontinence becomes more common. And young women in their 20s and 30s, about 30%. Middle-aged women's 40s and 50s, 40%. And in 60s, 65, beyond the menopause, over half of women will suffer from urinary incontinence. Another question I hear an awful lot is it normal to leak a little urine, or it's just a little urine? That's normal, right? No, it's not normal. Leakage is common, but it's not normal. And it's really important to understand that women who suffer from incontinence can do so in a very gradual and an insidious fashion, because it's a gradual and insidious problem. So often women don't think it's a medical condition and don't bring it up with their physicians or medical providers. This causes delay in women seeking care. And it's very important for us to communicate and to communicate with your friends and for you to know one doesn't have to live with urinary incontinence without seeking treatment. It's important. Although urinary incontinence isn't life-threatening, it's what I call quality of life-threatening. And it can affect a woman's life in many different domains. Physical, reducing physical activities because they don't want to leak. Psychological, they feel like they're old. They're concerned about the odor. They lose their self-esteem. Higher rates of depression in women with urinary incontinence. They reduce their social interaction. One woman said to me, I never go anywhere without being near my boyfriend, John. That means she was always near the toilet. She felt shackled to it. Padding, undergarment use, very costly and problematic. Some women will say they pack 2 suitcases when they travel, one for their clothes, one for their pads. Occupational, women who are working, this can cause a reduction in going to work and avoidance of intimacy. All right. Women with incontinence often suffer in silence, and this is part of the dialogue that we want to change. Survey of women suggests that women don't like to talk about this problem, even with their provider. And candidly, doctors aren't so great at it either. We don't do a great job asking patients about it. 3 out of 4 doctors in one survey, women after their visits during their annual screening, the doctor didn't even ask them or screen them about issues of incontinence. This leads to a delay. Women will often wait over 6 years before living with the condition before they even bring it up. We need to change the way we are looking at incontinence, bring it out from the shadows, bring it out from the bathroom, and start to recognize it. Times are changing, and one of the ways and one of the avenues is the pharmaceutical companies. The companies that are selling medications and treatment are going to direct-to-consumer marketing. This ad was during the Super Bowl last year for a new drug. You see this in print ads, media ads. Playtex has gotten in on the action. They have a product called Impressa that's designed to help prevent urinary loss. It works by inserting in the vagina, similar to a tampon, to compress the urethra to prevent the leakage. We have celebrity endorsements now, coming to the front, talking openly about female bladder leakage and urinary incontinence, and offering ways for women to get control. But more importantly, this I think is going to help bridge the big gap so we can start having a conversation. So there's 2 main types of incontinence. Stress urinary incontinence, or what I would call exertional loss of urine. So this is anytime losing urine with coughing, laughing, sneezing, or physical activity. Hey doc, I don't jump on the trampoline with my daughter anymore because it causes leaks. I wanted to play hopscotch. I can't do that with my daughter or my kids. It's common after pregnancy, particularly pregnancy that results with a vaginal delivery. So stress incontinence is basically increased pressure on the bladder that overcomes urethral resistance. Coughing, laughing, sneezing, all can create urinary loss by pressure and a lack of support underneath the urethra. The other type of incontinence is urge urinary incontinence, or I think this is the symptom when patients say, I gotta go, I can't make it to the toilet in time. Otherwise termed overactive bladder. Overactive bladder is to do with women have this overwhelming inability to resist the sensation to urinate. It has to do with early and inappropriate signaling of the bladder. Normally, we should be able to sense our bladder filling. If we're out and about, we're say, not now, I'm in the movie theater, I'm at the store, I'll wait till I get home. Overactive bladder is a problem when you're unable to suppress that sensation, and either due to increased sensation or muscle contractility, squeezing the bladder involuntarily, triggering urinary loss. So urinary urge incontinence is leaking urine with strong urge. It's also typified by urinary frequency and urgency. Often women can't hold their bladder more than 2 hours at a time. They feel like they have to go and they may leak right before they make it to the toilet. That's urinary urge incontinence. Sometimes it causes patients to wake up at night. Typical, normal is about 1 time, but anyone who's waking up 2, 3, 4, even 5 times a night to urinate is classic for overactive bladder. One problem patients often relay is that, "Doc, right when I get home, I pull my car in the driveway or I'm walking up the walkway to the front door, I put my key in the door. I got to immediately drop my bags, run to the toilet." And when I ask them, they go, "Yep, that's me." It's called lock and key syndrome. So who gets urinary incontinence? Women 2 times more likely than men. That sounds awfully unfair. Why is that? Anatomy and risk factors. Quick anatomy trip. We'll talk a little bit about the physiology. The kidneys filter the blood. The waste products of that blood filtration ends up in the kidneys and delivering it to the bladder through conduits called the ureters. The bladder is a storage organ, and it should store urine comfortably and painlessly until you're ready to urinate. And then once you're ready to urinate, it goes out through a tube called the urethra. One of the reasons women are particularly vexed with this problem is physics. They have a short urethra, very short tube. Men typically have a longer tube like a urethra, increased resistance. Women with a shorter tube, less ability to resist. And so anything that might cause detriment to the anatomy can trigger urinary incontinence, like vaginal delivery or occupational exposures. We'll talk about those. What are the risk factors? Age. As when we get older, we talked about estrogen. As estrogen recedes, the vaginal tissues change, leaving women susceptible to overactive bladder and stress urinary incontinence with the changes in the bladder lining. Pregnancy. Pregnancy itself does something to contribute to bladder weakening. If the pregnancy results with a vaginal delivery, the more vaginal deliveries, higher risk of urinary incontinence. Medical conditions with chronic repetitive straining, coughing, asthma, chronic constipation, smoking can all contribute to urinary incontinence. Activities. Women with occupational exposures. There was a study in Sweden looking at women who worked in nursing homes, transferring patients, lifting gurneys. Those women, when they compared them to age-matched controls, had higher rates of pelvic floor problems, including urinary incontinence. Obesity. The more weight you have, particularly if it's over 30, more pressure on the bladder, more pressure and stretch to the pelvic floor. And genetics. Some people are just prone. And this is a big area of research and trying to understand which women might be at risk. This is a slide demonstrating the older you get, the more common the problem is. I talked a little bit about pregnancy. This is a cartoon just to show the impact on the various structures of the pelvic floor during the act of childbirth. Here's the bladder. Here's the vaginal canal. Here's the rectum. As the fetal head comes through this space, it puts pressure here, pressure on the rectum. It can cause disruption of the connective tissue. It can cause stretch of the pelvic floor muscles. And all of those compression can injure the bladder and its support. Okay, what are the treatments for urinary incontinence? And that depends. Which set of symptoms are most bothersome? Is it exertional loss of urine? Is it urgency and frequency? And sometimes is it both? And then if they have both, we try to target which problem is most problematic for the patient. So if it's stress incontinence, is it urgent incontinence, or both types? The first best option for all types is pelvic floor muscle exercises, conservative, non-surgical, non-medical therapy. It's the foundation for all therapies. A little bit about pelvic floor muscle exercises, also known as Kegels. The pelvic floor extends from the pubic bone all the way back to the tailbone. And in between this area in a woman, this is a side view, is the bladder, the vagina with the uterus, and the rectum. And it's contraction of these muscles that allow the squeezing and the increased pressure around the outlets for these structures, like the urethra or the rectum. And in this instance, we're trying to contract the pelvic floor to increase resistance for urination. Contracting the pelvic floor also can actually feed back on the bladder and reduce urgency. called urge suppression. So as I said, pelvic floor muscle exercises are the same thing as Kegels, something patients get told to do all the time. One of the important critical features is that we have to recognize there is good evidence, level 1, controlled trials evaluating pelvic floor muscle exercises and its impact on urinary incontinence, and it works about 2/3 of the time. It can be done on your own or with the help of a physical therapist. Physical therapists who are actually trained specially to take care of women's health issues. They can work with patients, teaching them how to do them properly. Learning tips to identify the correct muscles is critical because when we ask patients just to do Kegels without any instruction, about 2/3 of the time they're not able to do them properly. It's very easy for us to identify. If I say go do an arm curl and I want you to strengthen your biceps muscle, it's very easy to see a biceps curl. If I ask you to do a Kegel exercise, it's impossible to see or know if you're doing it properly. And so this is where therapists can really help with that biologic feedback, the biofeedback, to help women learn how to do this proper skill. As with anything, it requires practice and a commitment. Because if you stop, there's evidence to suggest patients who have initial benefit but then stop doing their Kegels or their pelvic floor exercises, the incontinence can come back. It's an excellent first option. Even with the benefits of Kegel exercise and the pelvic floor strengthening, sometimes over the long haul, it's not quite enough. This is where we have to think about other issues, like surgery. And the good news is there's lots of good, minimally invasive options that we have available to help correct urinary incontinence for the long term, and I want to talk about those. Basically, we want to be able to have women run, jump, and sneeze without peeing. I thought these were cool hashtags. Hashtag mom problems and hashtag underawareness. All right, so I mentioned slings. Let's talk about them for a moment. What's a sling? It's a 20-minute outpatient procedure, home the same day, to correct urinary incontinence. It's been around for over 20 years in its current form. It's small incision surgery. It places a support under the urethra to prevent the loss of urine with exertion. So this is a video. Here's poor support, pressure triggering urinary loss. We need to do something to help with this support. We can use a sling. It can be a small piece of material, either permanent or your own tissue, that we put that provides that backboard and prevents urinary loss. Highly effective, very simple. And this is what it looks like. It can either be what we call retropubic, and there's ones that come out what we call transobturator through the groin. Small little piece, 1 centimeter wide underneath the urethra. Highly effective. With 10 years of data, over 80-year cure improvement rate subjectively at 2 years, long haul 70% plus. What else do we have? A laparoscopic surgery called a birch. It's also a same-day surgery using small incisions supporting the bladder neck from above. No implant, no materials. Bulking. Bulking's kind of like collagen. And we use it as a filler. Many women are sort of used to seeing celebrities with lip filler for collagen, and the material that we use is a similar type biologic material where we put it right at the bladder neck. Here's an open bladder neck. We put the bulking agent in like a collagen material, and it increases the resistance by coapting the urinary outlet. Increases the pressure and reduces urinary loss. There's also some new exciting things. At UCLA, we're involved with research, and one of the most exciting areas is looking at essentially what is essentially like stem cell-based therapy. We call cell-based therapy. It's using muscle cells, muscle progenitor cells, and we implant them into the urethra to restore function. The formal name is autologous muscle-derived cells, and we're doing studies ongoing at UCLA right now. We take muscle cells from a patient's thigh, we send them to a lab, we grow them up in culture. After a couple months, we bring them back, and we do an office-based procedure to implant them near the urethra to give new sphincter function for the urethra. No surgery, no foreign implants, it's your own tissue, and no incisions. All done in the office. Very exciting, very new. Getting back to the treatments, like I said, what are we going to do? So moving on to urge incontinence. Pelvic floor exercise is excellent first therapy for women with overactive bladder. Dietary and fluid modification becomes very critical for these types of patients. And we put patients on what we call a bladder diet. And it sounds a lot worse than it actually is. But it means removing triggers that might cause bladder overactivity. And here's a list of just a few of the ones and what I would call sort of the common suspects that might contribute to bladder overactivity. Caffeinated beverages, alcoholic beverages, carbonated beverages, acidic juices can all potentially cause bladder irritation and urgency and frequency. Spicy foods, even chocolate. Sorry, ladies. But removing these things from the diet can often give you great insight as to what your bladder triggers are, and then you then have control over your bladder. And it's all about giving control back to the patients. All right. Well, what if Kegels don't work? What if that bladder diet doesn't work? What else do we have? We've got other things: medication, Botox, neuromodulation, and posterior tibial nerve stimulation. So medications have been around a long time. You'll see them directly marketed to consumers, and doctors may have told you about them before, but they're all designed to help reduce the urinary urgency and frequency and the incontinence episodes. When we look at them over placebo, most all of them have some benefit. Sometimes it's mild. And the main class are these what we call anticholinergic medicines, and here's a list with their trade names. And these ones all function in a similar fashion. There's a more recent introduction. That's what we call a beta-3 agonist that acts a little different mechanism. And they all work pretty well, reducing urgency and frequency in incontinence episodes. There's no free ride. There is some side effects. The anticholinergics most commonly are dry eyes, dry mouth, constipation, and dizziness. And the beta-3 agonist, headache, joint pain, dizziness, blurred vision, all of them generally mild and not severe, but can be very annoying. And sometimes the side effects are more problematic than the condition they're trying to treat. So it's highly individual dependent, but used quite commonly. What else do we have? Well, for patients who don't do well with pelvic floor exercises, who don't do well on bladder diet and they're still having difficulty, who have tried medicines and it didn't work, or tried medicines and don't want to take it, we have some other options. How about Botox? Well, everyone's familiar with Botox used for cosmetic reasons. We can actually use it in the bladder. It's an office procedure. We take a cystoscope and we look inside the bladder and we place the Botox at different places within the bladder using a small injection needle. And when we look at the results, it reduces urinary urgency and improves bladder capacity in about 60 to 65% of patients. The benefit lasts, but it's not permanent. So it's usually only about 6 months. So often patients need 1 or 2 treatments a year. The side effects are very low, but are important to discuss because sometimes the Botox does such a good relaxing the bladder muscle that patients have a difficult time emptying completely. But that occurs in only about 3 to 6% of patients. How about other therapies? Well, there's a therapy that we've been using for over 10 years called neuromodulation. It involves placing a lead or a little wire right into the nerves above the buttocks. It's for a severe and refractive overactive bladder, patients who didn't do well on medications. And it's kind of like using a bladder pacemaker, where we put a little implantable pulse generator just in the back above the buttocks with a little wire that connects through little nerve roots in the sacrum. And this reduces urgency and frequency considerably. And the real nice thing about it is we can actually evaluate patients before we even do the implant with a temporary evaluation. And for women who have successful temporary leads placed, when they go on to get the permanent one, 80% reduction in urinary leakage. So that's very exciting, and no medication, and it's long-standing. The batteries last up to 5 to 7 years and just would need to be replaced periodically. Another type of therapy that's a form of neuromodulation is posterior tibial nerve stimulation. It's an office treatment, requires nothing other than a small acupuncture needle placed right at the ankle, and we put a little mild electrical stimulation through a little handheld battery pack. This little stimulation on the ankle works the nerves that work all the way up to the sacral nerve roots to affect the bladder and reduces urgency. requires a 30-minute session, so you come in the office, sit down with your clothes on, with your book, your iPad, or your Kindle, have a 30-minute session after the acupuncture needle is placed, and we do it for 12 weeks. And we look at this data, it works about as well as medication, We're still not sure about the long-term benefit, as often patients need boosters, maybe once a month or so. But that's very exciting for women who can't tolerate medications and don't want to go through the troubles of other therapies. So, to summarize, solutions for control: stress incontinence, pelvic floor muscle exercises, and dietary change. If one wants to do surgery, we've got slings, birch, bulking, all with excellent data. Overactive bladder, pelvic floor exercises, Kegel exercises, medications, Botox, neuromodulation, or that posterior tibial nerve stim. Okay, I think that's all I have for you, but I'd like to answer some questions, and I think Cleve may have some for us. Okay. All right, the first question is a diet question, and it is, should I remove all chocolate and alcohol and improve my lifestyle before I decide on surgery? I would say it's always prudent to utilize all conservative therapies before we talk about surgery. The draconian implementation of removing all chocolate and alcohol is kind of severe, but what I tell patients, I say, think of it like an allergy avoidance. Take it out for a few days and see if it makes a difference. If caffeine, if chocolate, if alcohol is a true trigger, you will notice a difference in your bladder function with just 2 or 3 days of removing it out of your diet. And then it's all about control, because if you notice your bladder does better, if you have to be out that day, you just skip your morning latte. But if you're at home and you're near a toilet, no problem. All right, another question on neuromodulation. Neuromodulation technique. What's the pros and cons? Is it as effective as mesh? All right, so that's a good question. I'm going to go back one slide just to differentiate. When we talk about neuromodulation, it's for patients with overactive bladder. It's the type of incontinence with urgency and frequency. The pros of neuromodulation is it doesn't require medication. It's a long-term treatment. Once you get it in and it works, you're done. You don't have to think about it for 5 years. It just requires some maintenance programming. That's very simple to do and easy to teach. And it's fairly safe. Complication rates with neuromodulation are very low. About 9% of the time, patients have to have the implant removed, either for that it's not working, or sometimes it can bother patients because it's sitting or pushing on the skin in an uncomfortable fashion. The question is it as effective as mesh? We don't use any type of mesh at all for our slings for overactive bladder. That would be for stress incontinence. So that would actually be treating two different things. I hope that answers your question. All right. When do you know if you have to have a mesh? All right, so I'm going to go to that question right now because I actually have a question prepared for you. So I'm going to skip that for a sec and we'll go back to that. So, is the mesh safe? And when do you know you have to have it? The mesh is safe, and it should be utilized for patients who have stress urinary incontinence for slings. What you've heard and what the FDA has intervened on is use of mesh for prolapse, which we haven't talked about today. That's prolapse of the bladder, prolapse of the vagina. When we apply mesh in those settings, the complication rates are, in my opinion, unacceptably high, and I do not advocate anyone getting transvaginal mesh for their prolapse. However, we have great evidence of safety and efficacy for slings, and so using mesh for slings I think is a reasonable idea because the safety and effectiveness of slings is well established in clinical trials that followed patients for over a year. And since 2008, the FDA has consistently differentiated between transvaginal mesh for prolapse and transvaginal mesh for SUI. We've got good evidence that mesh slings can help stress incontinence, not good evidence that it's safe for patients with transvaginal mesh for prolapse. That being said, we have non-mesh slings as well. We can use one's own tissue. So patients who are leery about it, and I would definitely advise you to talk to your doctor before you consider anything like this, to talk about using your own tissue as well as a viable option. This is just all this is where all the patients, when they come in, they've all seen this online and on TV. All right. If we don't have any further questions, I think I'll go to the Kegel question because that generated a lot of interest earlier. So I'm going to swing back here. So one important thing I'd like to leave you with is, how do I do a Kegel? All right, so pelvic floor muscle exercises are only going to help if done properly. And there's many ways to learn, and I'll show you one way. And I have a short cartoon. This is from Big Bump TV. So typically, the best thing to do is to do it when you're not distracted. Do it while you're lying down or seated. Going back, here's your pelvic floor, here's the rectum, the vagina, and the bladder. The first thing you want to focus on is the back. Think as if you're holding in gas, that you don't want to pass gas. The next thing to practice is think as if you want to contract, as if you don't want to pass urine. And then do them both together and hold it for 3, 5, even 10 seconds. Once you learn that skill, do 15 contractions for one set. 15 contractions, holding it for 5 to 10 seconds, relaxing and repeating. Do 3 sets a day, every day. That's a good Kegel exercise routine. All right, I think that's all we have for now. Oh, one more question? Got one more question. Cleve has it. All right, one more question. About leakage after urinating. Which category does that fall into, and what's the best treatment for that? All right, so the last thing we'll talk about is what this individual is asking about is what we would call post-micturition leakage or dribbling. Many women will feel like they're empty, they'll stand up, and they'll lose a little bit of urine. That is often reflective of incomplete bladder emptying, and it may be due to poor anatomy. So patients you might have a dropped bladder or a dropped urethra, which actually contributes to a small amount of urine pooling near the opening that's not evacuated while you're seated, and then once one stands, typically that small amount of urine can leak out. And that can be addressed with a more proper evaluation in the office. All right. Thank you for signing on today, and I appreciate your questions.